Hey guys, so we're going to be talking about acute kidney injury. So we're going to jump right in with what does your kidney do? So it produces aldosterone, it balances sodium and water content in your body, your blood pressure, electrolytes, acid-base balance. It metabolizes vitamin D and it excretes nitrogenous waste. Your role as a nurse in acute kidney injury is to recognize which of your patients are at high risk to develop acute kidney injury, implement preventative measures to prevent this from happening, and perform timely and thorough assessments so that if it does begin to occur, you know when it started and you can notify the doctor to jump in with treatment. So there is a very long list of risk factors. The ones that almost everyone can agree on are age of 65 and older, the presence of infection on admission, acute cardiac failure, acute respiratory failure, chronic heart failure, cirrhosis, leukemia, and lymphoma. There are 3 different kinds of acute kidney injury. We have pre-renal, intrarenal, and post-renal. I've summarized the very long list into little tidbits of things you should be looking for. So for pre-renal, I want you to be thinking conditions that interfere with renal perfusion. So this is things that are like intravascular volume depletion, so trauma, sepsis, vasodilation, also sepsis, increased or decreased cardiac output, and then a handful of meds, ACE inhibitors, norepinephrine, NSAIDs, and anything that causes hypercalcemia. Pre-renal is going to account for 30 to 40% of the acute kidney injury cases that you see. For intrarenal, I want you to be thinking anatomical damage to kidney structures. Think down the lines of ischemia. So most common in this section is acute tubular necrosis. That's going to account for 50% of the cases that you see. And what causes this is prolonged pre-renal acute kidney injury and nephrotoxic substances, and sometimes a combination of the two of them. So your post-renal, I want you to think obstruction. So a block in the flow of urine. This causes an increased pressure and reduced GFR in the kidney. We're thinking things like benign prostatic hypertrophy, BPH, clots, stones, tumors, edema, some meds, but be thinking obstruction of flow. So for your physical assessment, there are 2 big factors I want you to remember that you need to be looking for, and that is uremia retention and hydration status. So uremia retention looks like generalized malaise, fatigue, disorientation, drowsiness. And then for hydration status, if they are looking dry, so hypotensive, tachycardic, weight loss, dry mucous membranes, tinting of their skin, I want you to be thinking pre-renal. On the flip side, if they are looking overhydrated, so weight gain, edema, hypertension, excessive urination, jugular vein distension, I want you to be thinking intrarenal. Almost all of your AKI patients will be tachypnic as a compensatory mechanism for the acidosis. So the next topic is your key diagnostics. First, we're going to rule out obstruction. It's non-invasive because you can do it with an ultrasound. Second, urine output most likely will be decreased. As we just talked about, sometimes they can be peeing excessively, so it's not always a great indicator. And then creatinine increase, and this is increase above baseline. So if they have chronic kidney disease, obviously it's going to be increased, but if it's increased even further is what you're looking for. Always look at the whole patient. So the fourth one is your fluid challenge. So to determine intrarenal versus pre-renal, we're going to do a fluid challenge, usually starting with 500 mils of fluid. However, they do recommend to continue the challenge until you either A, see an increase in urine output, or B, begin to be concerned for volume overload. The early medical management of AKI is volume infusion to promote blood flow, to stop any nephrotoxic drugs, and to treat any conditions that may be causing this. So that's going to cover both pre-renal and intrarenal acute kidney injury. 70% of your patients will end up needing renal replacement therapy. So the indicators to receive that are 1, volume overload, 2, life-threatening hyperkalemia, 3, metabolic acidosis, and 4, toxin removal. There are so many different kinds of renal replacement therapy. We're going to briefly talk about 2 of them today. These are the ones you're going to see the most often in the ICU. So first we have hemodialysis. This is your traditional dialysis. Can be done outpatient, can be done in the hospital, can be done using a fistula, can be done using a dialysis catheter. This is powered by diffusion, so we're thinking concentration gradient. The pro is that it will pull small solutes, such as nitrogenous waste and potassium, out quickly. So if they are uremic and they do have hyperkalemia, this is going to pull those things out quickly to preserve heart function and kidney function. The con is that it has a limited removal of large molecules that would be like toxins, and your blood must maintain a rate of 200 to 300 mils per minute, and this usually leads to hypotension. So if they're already hemodynamically unstable, then traditional hemodialysis is not necessarily the right answer. So hemofiltration is otherwise known as continuous renal replacement therapy. They do have other kinds of continuous renal replacement therapy, but this is the one we're talking about today. This is by convection. So basically the fluids run in the opposite direction fast enough to pull things out of the blood. They also call it solvent drag. The pro is that it provides more gradual fluid removal, reducing the hemodynamic compromise, and it also removes larger molecules such as toxin removal and inflammatory mediators. That's important in sepsis. The con is that it is slow solute removal, so it's not going to quickly remove your uremia buildup and your potassium. Your role as a nurse is to monitor their weight and their intake and output, and you need to notify the physician if your patient gains or loses 0.5 to 1 kilogram in a 24-hour period. And on the urine output, you need to notify the physician if they make at or less than 0.5 ml per kilogram per hour. For respiratory, obviously the goal is for them to be breathing normal rate with clear lungs, but you're really watching for tachypnea. For your hemodynamics, you're going to be watching them the whole time they're getting fluid replacement therapy. Your cardiac rhythm, that's going to tell you what your electrolytes are looking like, even without labs. Like you can watch for the abnormalities, PVCs, PACs, peak T waves, things like that. And then uremia elevation back to drowsiness, disorientation, fatigue, generalized malaise. So obviously the goal is for everyone to be back to normal weight with clear lungs, stable hemodynamics, normal limits for their electrolyte labs, and no edema. So it always helped me to know why things were important while I was learning about them. So this is important because 50% or more of your critically ill patients will develop an acute kidney injury, and 50% is the mortality rate for acute kidney injury. So this means that 25% of critically ill patients will die because of acute kidney injury. So it's a big deal. Have a good day.